Well, good afternoon, everyone, and good morning to our friends on the West Coast. My name is Mary Dorshank, and I'm the Director of the National Colorectal Cancer Roundtable, and we really appreciate everyone making the time to join today. We're excited to offer to all of you today the first webinar sponsored by the NCCRT in 2016. And on today's webinar, we are going to be going over giving an intro of the CDC's Colorectal Cancer Control Program. So first off, let me say thank you to everyone for joining. I know there's a lot of interest in this topic, and we really appreciate everyone making the time to join us today. So I think, as most of you know, last summer the CDC awarded 31 grants designed to increase colorectal cancer screening among men and women aged 50 to 75 through a competitive process. This is a new cycle of the grant, and as many of you know, the CDC's Colorectal Cancer Control Program has existed for many years, and so I think we've received a lot of questions about how the new grants are different, how are they the same from the old cycle, and we are very fortunate today to be joined by our friends from CDC, Fei Wang, who's the Chief Chief of the Program Services Branch in the Division of Cancer Prevention and Control in Atlanta, along with Janaba Joseph, who is the Medical Director of the CDC's Colorectal Cancer Control Program. And they are going to be going over for us a basic introduction to the program, how it's designed to support evidence-based interventions, which systems it aims to support. I think all of you will want to know how partners can get involved, and then, of course, how the program will be evaluated. So many thanks to Faye and Janaba for joining us today. Just a few housekeeping items before we get started. We are recording today's webinar, and the replay and the speaker slides will be made available and shared with all of you. Please feel free to share the replay with any colleagues who are not able to join us today. And then also, not surprisingly, but because of the large number of participants, all participants are muted on today's webinar. But having said that, we still want to make sure that you get what you need out of the webinar. So we really encourage you to ask questions by using the Q&A function that you'll find at the right-hand side on the bottom of your screen. We should have time for questions after the presentation, and we'll definitely answer as many questions as we can. But if we don't happen to get to all the questions, we can email around any responses to any questions we don't have time to get to. And then you can always email us afterwards with any specific questions. Finally, we're always trying to improve our webinars. So when you get the replay, you will also get a short evaluation survey. Please help us out by taking just a few minutes to provide your feedback. We do take this advice very seriously and use it to improve future webinars that the Roundtable offers. So with that, I am very pleased to turn the webinar over to Fei Wang. And Fei, let me just pass the baton to you, and I will let you take over.
Okay, great. Well, first of all, thank you, Mary, and thank you to the Roundtable for the invitation to speak with Roundtable members. You know, we at CDC are a very close partner of the Roundtable throughout the year in addressing colorectal cancer issues and opportunities. So we have several key messages today. One is that this is the second round of 5-year funding for the Colorectal Cancer Control Program. The first set of programs have broken ground in implementing evidence-based interventions and population approaches. We're dealing with an enormously dynamic and changing healthcare environment that offers opportunities as well as challenges. And the new FOA that we just funded this summer incorporates what we learned from past experiences, and we are focusing on what works, on systems change, and the evaluation will be a big part of the FOA because we want to know whether we're meeting our outcomes and what it is that our grantees did that made the difference in success versus not. This slide pretty much defines for you the big picture of the Colorectal Cancer Control Program 1502, which is the new one. In this FOA, we funded 2 components. Component 1 focuses on health systems change to improve and increase colorectal cancer screening. Every single applicant had to apply for Component 1 and include this aspect of intervention as a part of their proposal. Component 2 was money that was set aside to fund up to 5 programs to actually reimburse for screening services, and we ended up funding 6 because 2 of the applicants received the same score when the applications were reviewed by independent objective review panel. Our long-term vision is we want to see down the road more organized cancer screening in this country, a fuller utilization of and integration of use of evidence-based interventions, increases in population-level screening among insured and uninsured, and to address disparities. And in this presentation today, we will focus only on Component 1, the health systems change and EBIs, because that is the priority of the FOA itself. This is a map that shows you who the colorectal cancer grantees are. We funded 24 state grantees, 6 universities, and 1 new tribal program, the Great Plains. This slide shows you a listing by name of all 31 applicants that were funded for the colorectal program, and in orange text are the 6 states that are receiving Component 2 funding to provide screening provision services as well. As I just mentioned, we are very interested and very vested in investing in what works. And I absolutely love this kitty photo because it clearly shows that this particular kitty is not using an effective strategy to try to get at the apples. So the focus of our program is to stop doing what doesn't work and invest in what does work. Component 1 of 1502 has 2 categories of priority strategies. One is the required, and that is to implement evidence-based interventions, including patient reminders, provider assessment and feedback, and the reduction of structural changes. Secondary EBI interventions are listed on the right side of the slide. And the point being here that they can implement interventions such as patient navigation, small media, and so forth, but only in conjunction with the priority evidence-based intervention. The funds for this program cannot be focused purely on, for example, small media, patient navigation, et cetera. Just to give you a little bit of a context of where we came from and where we're going, what this slide does is provide you with a broad timeline of the cancer screening programs here at CDC and what's happening in the healthcare landscape. Everything really started with the National Breast and Cervical Cancer Early Detection Program, which was authorized by law in 1990. CDC has had a breast and cervical cancer screening program across the U.S. since 1991. We funded a colorectal cancer demonstration project from 2005 to 2009, and that evolved into funding the first cycle of colorectal cancer control programs from 2009 to 2015. And in the meantime, the Affordable Care Act was passed, and the health insurance marketplace was started in October of 2013. Essentially, what we have here is a dynamic point in time of change for the program. And CDC, even before the Affordable Care Act was passed, was carefully looking at what was going on in the healthcare landscape. What does that mean for cancer screening in this country? And so with the new DP 15-1502, we factor all of these things into consideration in the design of the FOA itself. The health systems change emphasis that we are focusing on right now is really not new. Our plan since 2009, when we first funded the first set of states, tribes, and had a evidence-based intervention and health systems focus. At that time, though, the way the FOA was written, we were more restricted in how we used that money. We limited the amount of money spent on actually reimbursing for clinical service to 1/3 of the total amount awarded to each of our grantees, and the remaining 2/3 provided the supportive services such as the data systems, the patient navigation, and the remainder beyond that was used for, at the time, what we call screening promotion, working with policy and systems change. And I keep forgetting this little arrow here. Okay, and now the main difference is we've separated the two components more distinctly. Component one, as I said earlier, is to implement health systems change and evidence-based interventions with the intent to increase population level screening and more organized screening in this country over time, and that is the core and the priority component of this FOA. Back in 2009, when we were looking at the program, what we realized is that we really didn't have very much money in the colorectal program. We award approximately $23 million in the colorectal cancer program, and that isn't enough money to widely provide direct screening services. And at the time that we started the colorectal program, we had a new CDC director, Dr. Tom Frieden, and one of the first questions he asked us is, why are you even screening when 23 million doesn't go very far? And at that point, we began to look at the socio-ecological model and moving from focusing on direct screening to working on health systems change, where we have opportunity to reach and provide screening for many more people. Just to illustrate, you know, when you have a eligibility-based program with limited funding, whether it's colorectal cancer screening or with the breast and cervical program, which has a lot more money, you basically are reaching only a few of those who are eligible for screening. And as this illustrates, then, when you have to meet eligibility criteria, the program reaches low. In the diagram here, every one of these people are eligible for screening by the program, but we only have sufficient funding to reach the ones that are pointed out here in yellow. When you look at implementation of EBIs and a population approach with health systems change, this has opportunity to reach the universe of those who are eligible and recommended for screening by, for example, the U.S. Preventive Services Task Force recommendations. And this is where we are going now and into the future. So we also apply some of the lessons learned from the first round of colorectal funding in designing this FOA. What you see on this slide is the results of a cost study of the first group of states that were funded for the colorectal cancer program. Our grantees were doing good work out there, but what we learned by this particular study is while they were doing good work, they were not focusing on investing in what we know works, which is evidence-based interventions. And what you will see here is the top bar is mass media. Mass media is not an evidence-based intervention. There are also many others that are already investing resources in mass media efforts, including CDC's Screen for Life program, and those resources are available for grantees and partner organizations to use. So we don't want to focus our dollars on what is not an EBI and what others are already doing. In addition to that, there are many science-based, credible products out there that are developed by the American Cancer Society, the 80 by 2018 efforts of the roundtable, the efforts that we've invested in the Washington University MEAL, which is a web-based product that grantees can use to develop small media type materials. We also look to ask experts for their input on where CDC should be going relative to cancer screening. And we used a forum called CDC Grand Rounds to do it. That is a format that was introduced by the CDC director, Dr. Frieden, where each month a different topic is selected, and you dive deep into that topic and present the latest science and the latest recommendations. So in July of 2013, we had the CDC Grand Rounds on cancer screening. Ned Kalange with the Colorado Trust was one of the speakers, and he made a point, for example, that the healthcare system in this country is fragmented with little coordination, and he pointed out an IOM report funded by CDC and HRSA that highlighted the need for integration of public health with primary care. And I just want to acknowledge Dr. Jim Hutz, who is a very active member of the Roundtable and with the National Association of Community Health Centers, who was a member of this review group, and we, through our division director at the time, presented to the committee on the opportunities of public health and primary care to work together. In addition to that, Dr. Marcus Plescher, who was division director at the time, was really focused on the lack of organized screening in this country. Cancer screening in health systems is frequently opportunistic, meaning that if a woman happens to go to the doctor, if a man happens to go to the doctor for some other reason, they may remember or not remember to remind them that they are due or overdue for their cancer screening. And through the BNC program, as well as with the first round of colorectal program, we very much know that when you have an organized system, you have a system to bring people in for screening, to track their screening results, to make sure that they have follow-up of abnormal results, and for referral into treatment. So there's the entire loop from coming in for screening to resolution through treatment where needed, and identifying that this is a great need in our country. He was also a big fan of the kind of screening that is happening in, for example, in England, where they proactively send out FOBT appointments and kits to the population to come in for screening versus waiting for them to show up at a doctor's office. A third speaker we had was T.R. Levine, who is a very active member of the Roundtable. He's with the Kaiser, Northern California, and what they did is they identified a problem way back in 2004, 2005 of low colorectal cancer screening rates among the members of the Kaiser Family Foundation, Northern California. And they implemented an organized approach to cancer screening with outreach and inreach. In outreach, they mailed test kits to everyone who were due for screening. In inreach, they used EHRs to send reminders to physicians and other clinical staff to activate them in working with their clients to bring them in. And then they tracked the patients who had positive screening results to make sure that they got timely colonoscopies. And what they essentially saw is that over time, the colorectal cancer screening rates at Kaiser Northern California increased. And this is the kind of results that we want to see in the clinics that our colorectal cancer programs are going to be working with through the funding from CDC. So the key differences between the first set of colorectal programs and the second one is summarized in this slide. I want to point out a few of them. One is in the first round of funding, the scope was broad, working with mass media, with communities, and broadly promoting the importance of colorectal cancer screening. In the new FOA, the scope is narrow, specific, and with focused investment so that we can truly demonstrate what works and what doesn't, as well as to measure impact. Secondly, in the old FOA, we had broad-based partnerships working with screening promotion. In the new FOA, our grantees are required to identify specific health systems partners that they are going to work with, develop MOUs to work together to assess what's going on in those clinics, to establish baseline screening rates, measure screening rates over time, as well as to put in place interventions with EBIs to increase those screening rates. And the third thing I want to just mention is in the old FOA, we focused on using the behavioral risk factor surveillance system data to measure impact. Well, BRFSS is very broad, and you get statewide data that you may or may not be able to attribute to any specific intervention that was carried out. In the new FOA, we are going to be looking to partner health system data to measure the impact. Are the clinics we're working with the ones that are actually increasing their screening rates, for example? We are very aggressive at CDC, and I think our cancer division was a leader in that arena in establishing logic models for the programs that we run, which essentially is an effort that forces us to think about what are the long-term outcomes, intermediate, short-term, and intervention strategies. So what you see here is the logic model for the new colorectal program, which Janava will explain a little bit more when she speaks. The emphasis I want to put is that the interventions in the new colorectal program is within the partner health systems that they're working with and not broad community or statewide focus. In addition to that, you know, we want to do what's needed and want our grantees to do what's needed to optimize the chances to reach the most people to have an impact. So a favorite question I ask is, you know, why do thieves rob banks? And that's because that's where the money is at. The next question related to that is, how do we enhance colorectal cancer control program success? And there's three considerations. One is our grantees need to work with health systems that already have low colorectal screening rates. For example, it makes no sense to work with health systems that have screening rates that are already at 80%. They need to work with priority populations that have low screening rates, and they need to work with partners who are committed to increasing colorectal cancer screening. In addition to that, one thing that's very important is that CDC and its grantees need to plan, invest, and manage for success. By that, what we mean is our grantees need to assess the clinics they're working with to see what the screening flow is, what's working, what's not, to select appropriate evidence-based interventions. They need to implement community guide EBIs with fidelity because it is the published literature on the various interventions that have been shown to be effective. They need to implement intervention activities consistently, and very important, to invest adequate resources to deliver results. So what we really mean by that is put enough money into it so that you know if something works or doesn't work, it's not tied directly to the money. So not investing enough and having something not work is not a good idea. We are stressing continuously the importance of focusing. We can't do everything for everybody all the time, for example. Less is more. We're diving deep versus reaching broadly. And just the important notion of continuously monitoring the program, the progress with the implementation of interventions, and adjusting efforts along the way. And connected to that is the importance of constant measurement, evaluation, and applying those evaluation measures to refine the program and modify things as needed. What we're trying to do here between the grantee and health systems partner is to remind them as well that this is not their usual partnership with the healthcare system and with health partners. In the new colorectal program, except in the 6 states that we provided money for screening services, the remaining 31 states in Component 1, we are not buying clinical services. It's their partner who's going to be completing the assessments and implementing the systems improvements, implementing the EBIs in collaboration with CDC. It is not our grantees that go in and do it. They are a guest, they are our partner. They have much more of an influence role than a control role. Measurement and evaluation is important throughout. So it's a matter of investing the money in what's needed to achieve the goals with their health systems partner. And at this point, let me turn it over to Janaba, and we'll talk more at the end.
Okay, so I'm going to talk a little bit about our evaluation plans for the program. So I think the key for us was to develop the correct evaluation tool rather than trying to find a new nut, because we're not getting a new nut. We're stuck with the nut we have. So obviously evaluation of the CRCCP is a CDC priority and is required of grantees. We want to look to see if the program outcomes that we were looking for were achieved, particularly our short and intermediate term outcomes, and if they were achieved, how did we get there, and what did and didn't work, and what was critical to the success of what did work. So CDC uses the CDC evaluation framework, which actually was published in the MMWR well over 20 years ago, I believe. But if you want to find it, you can just Google CDC evaluation framework. And basically, it follows this circle. You start with engaging stakeholders, you then describe the program, focus the evaluation design, and just work your way around, basically. So we did that first by describing the program, and to describe the program, we came up with this logic model that Faye mentioned earlier. And really, it just describes what grantee strategies and activities we expect our grantees to do, what we expect our short-term outcomes to be, what we expect our intermediate outcomes to be, and then our long-term outcomes, which are truly long-term, which is decreased disparities in colorectal cancer incidence and mortality, and decreased CRC incidence and mortality. All right. So in order to get to our outcomes and the grantees' activities that Faye mentioned, we're asking them to implement evidence-based interventions. Why? Because we know they work, or they can work. So we're looking to the Guide to Community Preventive Services, which is created or put out by the Task Force on Community Preventive Services. And this chart just so it highlights the interventions that have been found to be effective for colorectal cancer. And we're asking them to focus on 5 of these interventions. We're looking particularly at client reminders, reducing structural barriers, provider assessment and feedback, and provider reminders and recall. And we are using small media as a secondary intervention, primarily because there's lots and lots and lots and lots and lots of small media floating around out there that's great and excellent. And we didn't think it was a good use of our resources to reinvent the wheel, so to speak, if the wheel was already rolling around out there. So just to define, some of these client reminders are written or telephone messages advising people that they are due or overdue for screening. Reducing structural barriers is reducing non-economic burdens or obstacles that make access to screening difficult. So language barriers is common, transportation barriers, things of that nature. Provider reminders, obviously, creating ways to remind providers to order screening for their patients, because obviously providers have a lot on their mind and this isn't necessarily primary. Provider assessment and feedback. So I think this is probably one of the most misunderstood ones, is to both assess, so to look at is the provider offering screening to their patients, how are they offering it, what is their screening rate, and then to also provide feedback, which is the part that usually gets chopped off, to sit down and talk with those providers and come up with ways for them to do better if they're not meeting the goals that they had set, and then small media. So we like logic models here. We have lots of logic models. So we have an EBI logic model for the CRCCP that sort of envisions how we expect all our different EBIs to work together and how those EBIs would lead to our designated short-term outcomes. And then we also have logic models for each EBI to describe how each of those EBIs should work. So we have a logic model, for instance, for provider reminders that describes the activities we expect our grantees to be doing and what short-term outcomes they can expect to see from each of those. I don't have those up there, but if you're interested, we're happy to share. So once we're done describing the program, then we have to focus to evaluation design. So the intermediate outcome, really, that we're trying to focus on is increase high-quality, appropriate screening among defined patient populations. So bottom line, we're looking to see an increase in colorectal cancer screening rates in the health systems where our grantees are partnering. So that's really our primary intermediate outcome. And then, obviously, if they do that, then we also hope to see increased adherence, increased rescreening, and just increased colorectal cancer screening rates across the broader population. And then we have a bunch of other intermediate outcomes that we're looking at there. So our evaluation question for our outcome is the CRCCP effective in increasing colorectal cancer screening rates in partner health systems? How are we going to figure that out? That's our main outcome question. And then we're also looking at processes questions. So looking at the grantee strategies and activities to figure out what are they doing and how are they doing it to get to our primary outcome. So those questions would include things like what is the reach of the CRCCP, who are their partners, which EBIs and supportive activities are being implemented, are they implementing consistent with the community guide. We're going to try to get at which combination of EBIs might be more effective as opposed to a single EBI or various combinations of EBIs. So in order, obviously, to assess any of that, we need some data. So our data collection strategy is a little different this time, where since they're working directly with healthcare systems, we're going to be asking them to collect clinic-level colorectal cancer screening rates. So for each health system, they're going to be working within that health system with a certain number of clinics. So we're asking them, when they're partnering with those clinics, to get a baseline screening rate before they intervene and do anything, and then collect annual screening rates from those clinics. We'll also be fielding a grantee survey that will get at some of those process questions about who they're partnering with and what they're implementing and how they're doing it. We also came up with this guidance as one of our tools, guidance for measuring colorectal cancer screening rates in health system clinics, which really just kind of goes through and describes how you calculate a colorectal cancer screening rate and relies pretty heavily on existing standardized measures like UDS, NQF, and KPRA, which is the one that IHS uses. So to put it all together, we'll be doing annual data collection with all grantees with our grantee survey and clinic data collection. Then we'll be also looking at secondary data sources that are available to us here at CDC about what they're spending their money on. So for the whole CRCCP and each grantee, we're going to be looking at their screening rates that they're achieving within their health system partners, what they're implementing and how they're implementing it, and how they're managing their program and their money. We will also be doing probably periodic studies with selected grantees, particularly to look at cost effectiveness and more in-depth case studies so you can get more information about what precisely they're implementing and how they're doing it. We expect lots of challenges along the way. I think the biggest issue for us is issues with electronic health records and data quality issues in terms of getting those colorectal cancer screening rates. It sounds so easy until you actually try to get in there and get it. It's complicated, and that's putting it nicely. That creates issues with interpreting changes in colorectal cancer screening rates. If the EHR doesn't reflect what's actually going on, and then they go in there and fix it, and then they get this huge bump in colorectal cancer screening rates. What does that mean for evaluation? We have some grantees that are working with lots of clinics. So that becomes then a burden in terms of trying to get that data. Some of our grantees are holdovers from our previous funding round, so they're already working with those with those clinics. So how do you assess the impact of any new activities under this round of funding versus what they did on the last round? And obviously implementation is not always cut and dry. It's not that they wake up and say on February 1st we're starting our provider reminders. It usually doesn't work that way. There's a lot of lead-in and sort of gradually getting things started. So there are some challenges, but like this little turtle guy here, we're not going to let that slow us down. So we're already working on ways to address many of those challenges. All right.
So turning it back to me, I guess what I would summarize based on what we've said thus far is the new colorectal cancer program is very much focused on making systems change with EBIs. We know that we're dealing in the real world, and as Janava said, we fully expect a variety of challenges, but we're not going to let that stop us. In the breast and cervical program, as well as with the screening portion of the colorectal program, CDC has a data system, and every single grantee submits the same clinical data on every person that's screened by CDC funds. Well, when you look across the country, that's just not the case. There's all kinds of data systems out there. So in the first year or so of the program, we'll be dealing with a lot of that, and hopefully we'll be able to move it forward to gather the data we need. In addition to that, just to give you some context, the funding awards were for this the new program to start June 30th of 2015, last year. So technically, we've been in business about 6 months. The actual notices of the grant award went out probably a couple months after that. The majority of time by our program consultants working with their assigned grantees has been things such as revising work plans and budgets to align with the intent of the FOA and to align with the logic model, because these are not funds that could be widely used for anything and everything. It's very focused because we want to know, for example, if collaborations between public health and healthcare systems even works, and how does it work, and so forth. And down the road, we would be able to have information to know what that would look like, and that would inform future directions. I was asked to talk a little bit about how we can work together to achieve 80 by 2018. And let me start off by saying that relative to colorectal cancer screening, it's going to take a collective effort of many of us to achieve 80 by 2018. And I think the last count I got from Mary Doroshank on the partners involved is the roundtable has received over 500 signed pledges from partners in the public and private sector to help reach this particular goal. And it truly is going to take the collective effort of all of us to do it. It would be important to leverage, to complement, and to extend and not duplicate or supplant each other's efforts, so we have an additive effect in moving forward to achieve what we want. So what I thought what might be best is to outline it this way. Number one is on the left side, I outline what our grantees are doing. They're overall responsible, for example, to manage the CDC-approved colorectal cancer control program and budget. They're accountable to the CDC procurement and grants office, as well as to my branch and the program consultants who are assigned to work with them. They totally need to focus on achieving outcomes in the partner health systems because that's where the focal point of our work is. We realize that, you know, among the 500 partners who've signed pledges, and in every state and community, there's others that have expertise and experiences and resources, and, you know, we would support and encourage our grantees to tap into the ones that can be helpful in carrying out the particular work plan activities that they have designed for their program. And we very much want them to share evaluation findings once we're a little bit down the road. So as they learn what works, what's not working, we fully intend to share those findings as early as we can versus waiting until the end of the 5-year funding. And we also want them to very much participate in broader colorectal cancer screening activities through, for example, the Comp Cancer Coalitions and others that are listed under the right side of this slide. From a partner perspective, the way we're looking at it is that, you know, partners have a really important role to help make colorectal cancer screening a community and statewide priority. The Program Services Branch, as I said earlier, we manage the National Breast and Cervical Cancer Early Detection Program as well as the colorectal program. And I can tell you that whereas there has been huge advancements in valuing colorectal cancer screening and in lots of activities going on around the country, and the important leadership of the round table with 80 by 2018, colorectal has a long ways to go, because if there's ever any threat or hint of a threat relative to mammography screening, you have every legislator and the USPSTF out there dancing on their toes, because women are mad when they're changing screening guidelines. I don't personally think we're there yet with colorectal screening, so I think we have a lot of work to do collectively to help make colorectal cancer screening a community-wide and statewide priority, increase the societal value for colorectal screening, making it the norm. And in that regard, you know, I think partners have a really important role to support or lead broad-based efforts in colorectal cancer awareness and other efforts to increase screening, and within individual entities and organizations to carry forth with whatever interventions might be needed to increase colorectal screening as well. We fully support and participate as well in, for our grantees to participate with Comp Cancer Coalitions and state colorectal roundtables where they exist. In addition, in the 11 states that have the 80 by 2018 state teams, we fully expect our grantees to participate and support that as well. As I mentioned earlier, there's lots of expertise, experience, and connections out there. Offer what it is that you know and expertise that you have. So for example, if our grantees are focused on a particular health system in implementing EBIs, but you run the program where you're already achieving success in it, or you know of others who are achieving success in it, foster the connection of those two parties so they can learn from each other in terms of what's working. If you have expertise in colorectal cancer and the grantee is conducting training for the health system they're working with to bring them up to speed on colorectal cancer screening and to implement ABI, make your expertise known so that they can consider including it or including you as a speaker in some of that training. As another broad category, as I've mentioned and as Janaba has mentioned, we're not interested in investing in things that other people are doing. So when it comes to mass media and products, Cindy Gelb at CDC with Screen for Life has a number of Screen for Life products available. The 80 by 2018, we worked with ACS in supporting the work they've done to do market research on different audience. All that information is available, and they've also developed some wonderful materials promoting colorectal cancer screening through the 80 by 18 initiative, and all of those products are available as well. So there's no point for us to reinvent the wheel. So, if partners have colorectal materials that are grounded in science, that are appropriate for the audiences that our grantees are trying to reach, by all means make them aware of it and collaborate in terms of sharing those kinds of materials. So I'm sure there's lots of other opportunities that I haven't even touched on, but very much so it is on the grantee level, because every grantee's work plan and approach to intervention through the CRCCP is slightly different depending on the health system they're working with, the clinic needs, and where the gaps are. And every grantee is working in a community and state that has different resources and expertise available to them as well. So it's a matter of, communication and identifying what makes sense to come together, to work together to help achieve the goals of our particular FOA. And with that, Mary, let me turn it over to you for the Q&As.
Wonderful. Well, that was excellent. We really appreciate your time, and this has really helped me understand, how the program is new, particularly since the last cycle, and how that might change our thinking about the program. So thank you very much for that thorough overview. We have a few questions that have come in. So the first, I think, is actually directed to me, is the 80 by 18, does the 80 by 18 goal include the full year of 2018, or do we need to be at 80% by January 2018 to achieve our goal? And I will gladly quote the chair of the roundtable and chief cancer control officer for ACS, Dr. Rich Winder, has said we are going to take every screening up to December 31st, 11/59 of 2018 to try to reach our goal. So we are certainly looking at this as a full year effort in 2018, and then of course because of data lag issues, we may not know how the screening rate that we're actually at in 2018. And I say that lightly, but one thing the question prompts is just kind of a little bit of reflection on what we're really trying to achieve. And I think we've always had a fear that people would think the 80 by 18 goal is too ambitious, and so I think it's worth saying that we need everybody to be a part of this goal, and we don't want people to be afraid of it. And if you're in a health system that is at, say, 7%, we need you more than ever, as Faye sort of touched on in her her presentation about where do we want to target our interventions. We want to target those who are struggling the most with screening. And so, you know, if a health plan starts at 7% and by 2018 they're at 55%, you can be darn sure we will be celebrating with them. So thank you for the question. We have another one from Emily. Faye and Janaba, you know, I know you guys are just getting started in the program, but are there specific examples you'd like to share about how you've seen partners support the CRCCP grantees?
Well, relative to the current FOA, I would say it's a little too early to say. But we did have a kickoff meeting in October with our grantees and included some speakers from the previous FOA. And I do recall, for example, that the grantees tapped ACS to actually go in and do the chart audits that created the baseline screening rates. As one example of how that occurred, and involve partners in the various community-wide, statewide trainings that were done to raise awareness about colorectal cancer screening, the importance of it, et cetera, where they reach broadly to providers or GI folks across the entire state.
Great.
But those would be, you know, some of the examples I could think of off the top of my head.
Yeah.
Great.
I'd also say that we certainly heard from grantees that they've been working with the ACS regional staff and other partners in their state to try to get a good handle on who's doing what and where, and try to really think strategically about what activities they're going to implement and making sure they don't duplicate or supplant what's already being done. So we have heard plenty of anecdotal stories of that nature.
Okay, great. And then I think as the program progresses, we'll definitely want to hear and share from you all about wonderful partnerships you've seen that, you know, others might want to mimic. So we do have about 8 minutes left, so we have some time for questions. If folks have them, we definitely encourage you to enter questions in the Q&A feature at the bottom of the email. And I will take moderator's prerogative and put you on the spot, Janaba. As you know, I am a fan of the document you all created for grantees about, you know, assessing baseline screening rates. To the point you just made, Faye, it's a question we get all the time. You know, at the time, I don't think it was cleared for broader distribution. Any progress in that area, Janaba?
Yeah, it's getting ready to jump into the clearance queue, which
yay,
hopefully will not take forever. But you know, with all things CDC, they're formatting issues. It has to be 508 compliant, et cetera, and so on and so forth. So that might take a little bit of time to get ironed out, but we will get it cleared and make it publicly available on our website or somewhere where people can easily find it.
Great. Thank you. I appreciate that very much. And Faye, you and I have talked a little bit about the role of screening navigation in the program, and you know, I think a lot of roundtable members are fans, particularly when we've seen it done really well. You know, but it is sort of described as a secondary intervention in you know, in the current CRCCP program. Do you want to talk about a little bit that to explain why and how you see that fitting in now?
Yeah, I'm happy to do that. Well, let me make a general remark first, and that is, you know, through breast cervical as well as colorectal, we are supporting patient navigation efforts, and in fact, with the New Hampshire program, we've been conducting a study on the effectiveness of their patient navigation model and have found it to be of such high effectiveness that we are going to be working on making a replication package for it so that others can learn from it and do it. The main thing the main point I want to make about what is a secondary intervention is that in the case of patient navigation, we do support it, but we don't want patient navigation to be operating out there in isolation of tapping into reminder systems, tapping into following up with patients that have been sent reminders to come in and so forth. So the main point is to make a connection between the two and using the data available to identify, for example, if 1,000 people were sent out reminders for colorectal screening. Well, gosh darn, how many of them actually came into screening? And tracking the data on that will be an important role of the patient navigator to measure how successful they are in bringing men and women in for screening and using data so that they know that if someone has a positive result that they actually get into diagnostic testing. If it's a FIT-based program, that if they sent out FOBT kits, well, what % was actually returned and following up on that. So the main point being that, yes, we support patient navigation, but please tie it to the primary evidence-based intervention that will be important, and don't operate in silo by themselves.
Well, that's a great response. Go ahead. I'm sorry, Janava?
Oh, nope, that was Bay again.
Okay. Well, that's an excellent
So, Mary, let me make one other point is, you know, in the early data we had on the colorectal program, the first group of states that were funded, and we were looking at the grantee survey and what grantees were doing. Well, one of the highest activity was small media. And so I kept saying to our grantees, you know, you guys are doing what's easy. Handing out brochures is easy. That doesn't necessarily work in isolation of tying it to a systems change and the intervention. So small media ended up on the secondary side, and it's our way of saying, don't just print and hand out brochures, tie it to a reminder system intervention.
I like that advice very much. And I think to your point, when screening navigation is done well, it's so exciting, but not everything that's called screening navigation is truly high quality. But that's also great news about the replication package that's coming out of New Hampshire. We know Lynn Butterly just does awesome work. All right, well, last chance for questions, everyone. That was just excellent. So thank you again, Faye and Janava, for that wonderful overview, and thank you to the CDC for making our webinar series possible. Learned so much and have loved working with you both throughout the years. And just an announcement for everyone that is on, we will have our next webinar on February 9th, and we are releasing an updated 80x18 communications guidebook, including new tested messages in Spanish, which we're extremely excited to share with all of you. And then perhaps even more excitingly, on March 8th, we will be having our annual 80x18 webcast, which is less of a webinar and more of sort of a TV show about all things 80x18. So please save the date. We'll hope to have all of you join us in registration. Information about both events will be coming out soon. If you have any follow-up questions, please don't hesitate to email me. I'm sure Faye and Janava wouldn't mind additional emails as well. And thanks to all of you for joining. I really appreciate all the time that you all have put aside to share with us today.